Hi guys, I'm Dr. Marwah and welcome back to the channel. So today I can say that this session is designed where we focus on image-based questions which constitute about 10 to 15% of any exam. In the next forthcoming exam is the INI-CET one, which is going to be heavy on the images. So what I can say is the next 20 minutes I'll be doing like 20 very critical images before you that are mostly graphs, I can say, because when it comes to histology slides or ECG based slides that we have already done. So today it's mainly the graphical interpretations that are required. And trust me, it's the silent villain in the exam is actually not like those twisted questions of medicine or surgery. It's actually those graphical interpretations which can go anywhere and that can result in errors of judgment. So every time we have those graphs related to box and whisker plot, or whether it's a Kaplan-Meier survival or it's a Sigurd-Anderson normogram that I'm gonna show before you, it causes the heart to race fast, and then errors of judgment can occur. So let's focus. Let's try to do it quick and precise. And obviously, like with analysis, it's not that this is the answer to a question. We'll have a rational, a solid one for this. So do comment in the chat box if you're ready for this. Accept the challenge. 20 important graphs in 20 minutes. That's the target for today. And comment ready in the chat box quickly so that we can get started. Also, a couple of you can just give a thumbs up also so that I can just know that the audio and the visual part is fine, though it looks pretty decent to me at the moment. So if you can read a meme in a short duration, I mean, read a meme and we laugh over it. Similarly, today we're going to do a graph and we're going to laugh over it in a sense that, oh man, this was so simple. So the first one is right here in front of you. Do comment in the chat box what is the name of this curve that I've shown before you. And then obviously it's used for evaluation of status of ABG of a patient, whether it's metabolic acidosis or alkalosis. So yes, guys, I'll just zoom into this particular part of the image where the X is given, and you have to comment on the X for this one. So I'll wait for your interpretations meanwhile. And the simple logic is the name of this graph is Sigurd-Anderson normogram. And the Sigurd-Anderson normogram, why do we use it for, is primarily because we want to assess whether patient is in metabolic acidosis, alkalosis, whether it's an acute variety or a chronic variety. So as I zoom out, you can check out the options here as well. And yes, guys, let's have a look at what you think is the right interpretation for this one. And by this time, I think everybody can pick up that if I move to this particular side, then anything less than 7.4 going towards 7.3 would mean that there is acidosis present in a patient. So every time you say this or see this Sigurd-Anderson normogram, the first thing that you're supposed to check out is that this is Sigurd-Anderson normogram. Yeah, this would help you build up your scores related to INI-CET as well. So the message here is, at the moment, like what I'm trying to say is that my patient could be having metabolic acidosis if the graph representation is as follows in front of you. And you can do two entries quickly. One is going to be metabolic acidosis and alkalosis. Obviously understandable because there is okay, I'll zoom out a bit. Yeah, metabolic acidosis and alkalosis. That's because pH is less or pH is more. So those two curves that are shown at the moment help you identify like what is the issue in a patient. And then you have to look at the X component. So guys, there is respiratory acidosis for both of them. I'll give you the logic here also, but then the point is for the first one, we call it acute respiratory acidosis. Why I'm calling it acute is because in this condition, the bicarbonate values are hitting normal. Like you check out the bicarbonate values here, it is normal. But in the one that is mixed as X, we are going to call it a chronic respiratory acidosis. Why? Respiratory acidosis because PCO2 is super high, like values of 80. Like if you look at the PCO2 of the patient, it is super high and the pH is less, so it is respiratory acidosis. Now check out the bicarbonate value. The bicarbonate value in this case are like values of like 30s and 40s, which is much higher as compared to normal. That means compensation process is working, and therefore this would be an interpretation which I can say is related to chronic respiratory acidosis in a patient. So the correct answer for the first curve here is option number B, and I hope that you were able to analyze this and give and come on to the correct answer for this one. This is called as Sigurd-Anderson curve. You need to have a mental orientation for the same. And yeah, on the right hand side, I'll write down that interpretation once again. That is acute respiratory alkalosis. Well, how do you know that? The bicarbonate value for this one will again be normal. But if it is going to be a case of chronic respiratory alkalosis, then the bicarbonate value in the patient will begin to fall. So the interpretation for this one is very simple and straightforward, that if you listen to the ABG section, you will be able to interpret this relatively better. And if you're not able to, then what you need to do is just remember, first pH कम है तो एसिडोसिस, pH ज्यादा है तो एल्कोलोसिस, इतना तो क्लियर हो गया ना। मेटाबॉलिक एसिडोसिस में तीनों चीजें कम होती हैं, pH भी, PCO2 भी, बाइकार्बोनेट भी। सो दिस एरिया में अगर आप देखोगे तो pH भी कम है, बाइकार्बोनेट की वैल्यू भी कम है और PCO2 की वैल्यू भी कम है। तो अगर तीनों चीजें कम आ रही हैं, दैट इज व्हेन वील से दैट दिस इज मेटाबॉलिक एसिडोसिस। अगर तीनों बढ़ जाते हैं, देन वी से इट इज मेटाबॉलिक एल्कोलोसिस इन अ पेशेंट। एंड देन द मोर इंपॉर्टेंट एस्पेक्ट इज फॉर रेस्पिरेटरी एसिडोसिस एंड एल्कोलोसिस, द इंटरप्रिटेशन इज बेस्ड ऑन दैट C2 वैल्यूज आर टू बी हाई। तो अगर आप यहाँ देखोगे, जो ऊपर वाला एक्सिस है, यहाँ पे 3 डायमेंशन है, X भी है, Y भी है एंड Z एक्सिस भी है। there's a CO2 वैल्यू दैट इज गिवन विच इज एलिवेटेड, तो हम बोलेंगे रेस्पिरेटरी एसिडोसिस है। अब बाइकार्बोनेट अगर नॉर्मल है तो that is acute, and if it is elevated then we'll say chronic. So here the answer is option number B for the first entry that I made. And this session I think is like for INI-CET, and for those guys who are like gunning for that ranks, the coveted ranks, then this should be a spot on interpretation for you guys. तो इसको एक बारी ग्राफ को एक बारी you need to take like a picture of this and practice this. और अगर नहीं पढ़ा है कभी भी तो भाई physiology है, right? We are doing integrated study today, so this is like a physiology curve, Sigurd Anderson, that helps us analyze the graphical representation. Moving to the second one for today, he's asking regarding that pressure volume curve that we are able to analyze. So for the pressure volume curve, like this black dot marking is the one that is being asked here. And he says that what does this black dot marking indicate regarding the valves opening? So I'll draw the marking in this particular case, that is the filling part that is happening in the heart of the patient. Just mentally visualize, जब filling होती है तो mitral valve open करता है, and when filling is over, then the mitral valve will close in a patient. So here the blue dot is mitral valve opening and this is mitral valve closure. So you just need to get the interpretation. As far as the filling part is concerned, that is pretty straightforward as I've highlighted. So the main part is the black dot that he asked is where the mitral valve part would be affected. So I think we are got it. We are sorted for the second one where the mitral valve is opening, the filling part. And now we will talk about like what is going to be the interpretation for these curves, especially with respect to conditions like MS, AR, then is mitral regurgitation and aortic stenosis. So we have to take into consideration the change in the shape of the curve. And for the change in the shape of the curve, I'm going to give you a curve here where you can notice the curve has become relatively, I would say breadth-wise, it has become narrow. And the vertical height of the graph is increasing. So one in a pressure volume curve, if there is a narrowing present and the breadth is less, one thing is clear that it would be related to stenosis. Now the issue arises that how in a 30-second period, will you pick up whether it is aortic stenosis or it is mitral stenosis? The logic is simply to be remembered that if it will increase vertically, if this graph will increase vertically, then it will indicate aortic stenosis, because then the aortic valve opening will take relatively much more time. Why I'm saying that aortic valve opening will take more time, because there's an obstruction present in a patient. So therefore the left ventricle will have to apply more force to be able to open the aortic valve. So we are having is a delayed opening of the aortic valve of a patient. So the vertical part is increased, which is why the answer in this case would be valvular aortic stenosis. And in contrast, like if it is going to be mitral stenosis, then the curve will become smaller in size overall. Like I can here give you a couple of representations which are critical for understanding this pressure volume curves related to the heart. In the first image, like you can comment in the chat box also. For the first one, you can notice that the end diastolic volume in the patient is becoming lesser. The graph is becoming smaller in size than normal. There is less filling in the heart of this patient. As a result of this, the first image that I've shown here before you indicates mitral stenosis. In the second image also, you will notice that the breadth of the curve is relatively shorter, but the vertical height is more. So the second one that I mentioned here before you is for valvular aortic stenosis. So first message is, if you just focus on the English word stenosis, stenosis would tell you that there is going to be a narrowing that is present. So narrowing tells you that the graph will also be smaller in size, but then if it is going to be decreased horizontally, then you will say MS. If it is decreased, if it is increased vertically, but the breadth is shorter, then you will say aortic stenosis. So 1 and 2 are very easy to pick up in a question. Let's pick up the third one here and the fourth one. Like you guys can comment here. I think there's only one thing that is left. You notice this shape, this would be oval, and there is like little bit of area that is left here, because in this condition that I'm discussing here, the aortic valve opening part would definitely be affected. So if you look at this oval curve that I've highlighted before you, you can notice that because there is a mitral regurgitation occurring in the patient. So due to MR, what will happen is that less blood will be going out of the heart. So aortic valve opening will occur relatively, at a different time or earlier than what it normally should be. So we are having a curve that is significantly reduced there, and therefore this oval shaped curve is that for mitral regurgitation. The message is, if you get a curve that is ballooned up, if you get a curve that is super ballooned up, both vertically as well as horizontally, like you can notice the ballooning is occurring in the third curve and the fourth curve also, that numbers that I put, the third and the fourth one. The final message is, if the ballooning is occurring only horizontally, then answer it as mitral regurgitation. I can go into the logic of these also with respect to end diastolic volume and the stroke volume part, but now is the time when we have, like, exam is like a couple of days away. So what we need to do is have a quick interpretation, and that quick interpretations are, at the moment before you, in stenosis the curves will be having lesser breadth, and if it is smaller versus taller, MS versus AS. If it increases only horizontally, the ballooning part that is happening, then oval shaped, then you will say MR. And if it increases both vertically and horizontally, then you will say aortic regurgitation in a patient. And yeah, I mean, the pressure part is another way by which we can interpret this as well. So if you want to go by pressure situations, be my guest. Otherwise, like, the shapes of these help you analyze the data pretty straightforward. Let's do this question from a different way. And this time I have a patient of infective endocarditis. He is having a hyperdynamic precordium, right? The main part is, okay, the MR part, no, the MR part is logical, because see, in mitral regurgitation, all the blood that will leak from the left ventricle to the left atrium will come back in the ventricle also, no? So therefore, in this condition also, the end diastolic volume will tend to increase, but what is going out of the heart is less. Why less is blood going out of the heart? Because mitral valve is incompetent. So it's all based on the hemodynamics part. And if you want to go by pressure, it's okay. But otherwise, just the shape part would still help you analyze this part relatively easier. And now we have a chap with infective endocarditis. He's having a displaced apex beat. Now, if I'm having a displaced apex beat present, that tells me that there's a chamber enlargement happening. Auscultation is revealing a early diastolic murmur. I think you guys can quickly comment on the answers for this one. Yes, I think there were a couple of people who did comment on the answers rightly, but for this one, yes, I'm still waiting for the comments to come up here. Mitral regurgitation, yeah, I mean, the blood would come in aortic regurgitation also and mitral regurgitation also. In both of them, ultimately the end diastolic volume will increase. But then we need to pick up the differences here. One, you can solve it by the murmur, but even if you don't solve by murmur, the bottom line for this particular case would be, I'm getting B in the feed. You see, this is aortic stenosis as we discussed, no? And this is mitral stenosis. Patient is having a early diastolic murmur, and more importantly, he's having a displacement of the apex beat. So there's a chamber enlargement. So either it will be MR or it will be aortic regurgitation. Now, if it is mitral regurgitation, there will be a systolic murmur in a patient. And if it is aortic regurgitation, there would be a diastolic murmur in a patient. So the correct answer for the current situation that I've given here before you is early diastolic murmur. That is a feature of aortic regurgitation. So the correct answer for this one is option number D. I think subsequently, like, most guys were able to analyze this relatively better. And I state this again, mitral regurgitation also, end diastolic volume is more, aortic regurgitation also, but then the difference between the two can be made up on the basis of the murmur part. And more importantly, apart from this, the hemodynamics will also be changing now, because aortic regurgitation, the blood is leaking from aorta back into the LV. And in mitral regurgitation, it is from LV to LA, which is the reason why the change in the shape of the curves can be picked up. So pretty straightforward interpretations as of till now. And only one where I had a bit of hiccups were with respect to the first image of the Sigurd-Andersen normogram, which the markings that I've done at the moment today before you are the ones which are to be practiced, and a bit of ABG, if revised, will make it easier for you. If you had any issues with Sigurd-Andersen, just type Sigurd-Andersen and you'll find a video of mine regarding detailed discussion of 15 minutes about it, but then we have to do it faster today. Okay, Ji, comment on the flow volume curve. In this particular case, you noticing that bottom is inspiration, then is expiration. And normally we have is like a curve that would be appearing in this particular fashion. And in this case, what is happening is that there's a flattening of the curve that is happening. Inspiratory part flattening is also there, and the expiratory part flattening is also there. So if we are having a flattening of both the sides of the curve, then the possible reason why this could be happening in any patient is a tracheal stenosis. And that is why we will say obstructive pattern, obstructive because this is flattened. So less air is going in, less air is going outside, and this would be a fixed central obstruction occurring in a patient. So when we check out the shape of the curve for asthma, it is obviously easy. We are able to pick up that spooning of the curve that we are able to identify. But this time the obstructive lesion that was discussed here was slightly different in a sense that it was causing narrowing, which could be probably explained by a prolonged intubation. Like if somebody is intubated for more than 7 days, that tracheal stenosis can occur. So less air will go in and less less air will go in and less will be coming out also, which is why the flattening part can be explained here, which explains the correct answer for this question as option number D. Okay, guys. Moving to the subsequent question, we are talking about a plasma concentration versus the time graph, which indicates the drug absorption rate. In fact, this I would rate as the easiest one among all of these that I've currently discussed before you. So as far as area under curve is concerned, that would be total drug exposure. So that obviously cannot be the answer in this question. I'm ruling out at least one option for you guys. And minimal effective concentration, I mean, he's asking you regarding the absorption of the medicine. And for absorption of medicine, we need to have is a low T max in a patient. The correct answer in this case is option number A. The simple rationale is that the drug will act, this value has to be the least. You see, Cmax is the peak level of the drug that would be obtained. I mean, the Cmax is the peak concentration. But to achieve this peak concentration, if a drug will be having less Tmax, then the peak concentration will be achieved relatively earlier. If the Tmax would be increased, then the peak concentration would be delayed in a patient. So this is one of the easy curves that I currently mentioned before you. That would be option number A for Tmax. Cmax is the peak concentration, as I've highlighted. Area under curve would be the total drug exposure that would be happening. And then is the maximum toxic concentration and the effective concentration, which are represented on the y-axis. So pretty straightforward. Yeah, I think there was a delayed relay coming in for the tracheal stenosis curve that I have explained. Fine. Calculating the therapeutic index of a sedative drug whose dose response curve is given. So you can see that there would be death happening in a patient. So what I'll just do is take care of the median toxic dose. Like I have to calculate the therapeutic index. So all I need to do is simple mathematics. That is a median toxic dose. That would be like 200. And then I'll also take into consideration the median effective dose. And if these questions that come, no, they are going to be one-step division or they're going to be one-step multiplication. Never anything going beyond that. So even if I was looking at these values casually, either it would have been like 100 by 200 or it would have been 200 by 100. I mean, either it is 0.5 or it is 2 in a question. So here, like the toxic doses value to be given on the x-axis 200, the median effective dose value is given to be 100, and what you can see in between is that 120, that would be the effective dose for majority of patients, that is 120. So if I divide this therapeutic index, it will turn out to be a value of 2. The correct answer for the current question on the focus, that is the 7th one for today, is the second option. The only thing I can do in this question wrong is, in a rush to answer, I can maybe answer the numerator and the denominator to be swapped, which will change the answer to 0.5. So 7th is sorted. We come to 3 curves present here. This is actually in contrast not looking yellow, it's looking more of an orange one. So I just put an arrow. I mean, he's just asking you what this arrow denoted curve would represent. 120 would be the value which will be like, one is like 50. ED 50 means 50% of the median effective dose. No, when it is 100%, I mean, that would be representing that where the drug would be having maximum effect. That is 100% of patients would be suffering from a sedation. No, one is 50% of patients are having a sedation, 100% of patients are having a sedation. So ED 100 is the value where, like, the max patients would be. But what we need to take into consideration, therapeutic index, is the median value for the toxic as well as for the median effective dose. For the vertical curve, for the curve that I marked with the vertical arrow, what you need to check out is that the TLC of the patient is increased. The main point is that on the x-axis, the increment is occurring here. No, on the x-axis, the increment is occurring horizontally towards like 6, 7, etc. So the TLC of the patient is given to be elevated. The moment I say TLC is elevated, it indicates that there could be emphysema, there could be air trapping occurring in a patient, which is why the answer in this case would be given as obstructive lung disease. Absolutely right, guys. I think this is not a normal lung function. No, normal TLC is 6 liter. The curve in the middle is that for normal lung function. Then is a chota lung. That chota lung would be for restrictive lung disease like interstitial lung disease per se. And if you focus on the curve where like the TLC part is increased in a patient, that indicates a residual volume that is increased, and that would help me in analyzing the diagnosis of this patient. So pretty straightforward a representation. Just check out the TLCs more and you have is a interpretation for this case. Okay. Next is a patient who is a woman and she's come with like getting tired very soon. The FEV1 and the FVC values are given with a DLCO value as well. And he says comment on the diagnosis in this case. So what I will do is that I'll take on calculator timed vital capacity. The timed vital capacity value is FEV1 divided by FVC. FEV1 in this case is like 4 liter. FVC is about 5 liters. So if I divide this, the value will turn out to be 80%. That is one. And the second thing is that the DLC of the patient is reduced. So FEV1 of 0.8 will either be normal or will indicate most of the time restrictive lung disease. Well, to be sure, I need a DLCO value also because DLCO in the patient is less. So it will always be identifying here for diagnosing this patient as that of interstitial lung disease. That would be a non-specific interstitial pneumonitis. For option number A and B, for option number A and B, what you will notice is the standard presentation, which is FEV1 FVC ratio in this case will turn out to be less than 0.7. So A and B were ruled out. I'm left between myasthenia gravis and non-specific interstitial lung disease. This can be a report of myasthenia gravis patient also because respiratory muscles can get involved. But in myasthenia gravis, the diffusion capacity of the lung for carbon monoxide would be normal, and normal values of DLCO are between 80 to 120%. Normal DLCO values are between 80 to 120%. So since in this question the DLCO is less, that is why the answer here is non-specific interstitial pneumonitis. And okay, Sagar, not an issue, but a good one. You picked up a good one for today. Okay, Ji, fine. So the old war horse was retired recently, right? So moving to the next one, the 10th one, oxyhemoglobin dissociation curve. You always know that mnemonic right turn cadet, but I'll not get into the right turn cadet. I want spot answers, man. Next 10 seconds, I want you guys to hit the comment button for this one. The curve is shifting towards the left. And the curve is shifting towards the left. You see, when you have an increase of temperature, metabolic rate, carbon dioxide levels, the curve tends to go towards the right. In all of these three conditions, guys, the curve would always be going towards the right side. I mean, that right turn cadet is not required. सब सारे increase में curve right में जाता है except pH. Because when carbon dioxide will increase, no, when carbon dioxide will increase, pH will fall, na. And when pH will fall, the curve should be going towards right in a person. But here it is written increase pH. The correct answer for this one is option number A. This is the silliest mistake that anybody can make here. So do practice the parameters that are going to be related to the shift of the oxyhemoglobin, the sigmoid shaped curve shifting towards left and right. The logic in my opinion is whenever any parameter is increasing, whether it is 2,3 dpg, whether it is carbon dioxide, whether it's going to be pH, I mean all parameters may increase लिखा होता है except one, the pH, where pH should be falling for a right shift, and here it is like ulta, it is written increase pH, which means a left-sided curve would be occurring in this patient as is represented in the dotted red line. So the correct answer for this one is option number A. Yeah, I mean shift to the left is increase pH, perfectly fine. Then is a graph showing the results of a screening test, and is saying that the cutoff is reduced from point number B to point number A. Best example for this I can say is because he's himself written the word reduced, that will make it easier for you. Like I can mention American Heart Association cutoff for hypertension. Earlier the AHA cutoff was 140 by 90, and then for hypertension they decreased the cutoff to 130 by 80, by which you notice that almost 45% of the world is turning out to be hypertensive. So what we are trying to do is make a diagnosis relatively earlier, and that for early diagnosis in a patient, I mean the sensitivity part is increasing. You see, initially this was being called as a scam because hypertension is like big business. You know, most pharmaceutical companies make a killing out of selling medications for hypertension, which have to be taken on a lifelong basis. So initially people were saying that AHA is doing a scam by lowering the cutoff for hypertension, but they're logically right because the burden of the disease is so much. Hypertension is a cause, as a silent killer, that you need to decrease the threshold for detection, and if you decrease the threshold for detection, then more people can be identified, and therefore like the sensitivity in this part will increase. So the correct answer for the 11th one is option number B. Pretty a straightforward one. Okay. Then is that curve of action potential. I mean, the cardiac action potential versus the nerve action potential graph is a little different, as you can see here. And he's talking about that point X, or the peak of the curve that we are talking at the moment. So we are having first the firing potential. And following the firing potential, we are having overshooting above the RMP of 0. We are going in a positive side. So when we go towards the positive side, then sodium channels are inactivated. And at the same time, the potassium channels in the patient will begin to open. So X is the value at which you need to remember that the channels are going to be completely inactivated and the potassium channels are going to be open. So the correct answer for the 12th one on the agenda is option number B. Simple role of sodium potassium is what is being talked about. And at the height here, when we say that the RMP is hitting 35 millivolt, that's where the sodium channels are inactivated. Potassium channels will open, and gradually the repolarization process will occur, followed by a hyperpolarization. The correct answer for this is B. I also want to draw your attention to a question that came, I think this was FMG exam, where they had put pointers like these. And you just had to, select for the absolute refractory period. And my absolute refractory period is where the sodium channels are inactivated. No? If I have a sodium inactivation, whatever stimulation you will do, nothing is going to happen. Like if you focus that you're going to keep your phone away and just study for the next couple of days, then no distraction will ever be disturbing you, right? You keep your phone close to you, you check it out. So similarly here, the inactivation mode of the channel will cause an absolute refractory period that if you continuously stimulate, there would be no effect happening on the tissues per se. So the correct answer for this one is B. And along with this, no potassium channels, sodium channels are completely inactivated is the technical word for the X part, right? They don't close. It's a wrong statement to say closure. It is inactivation word, which is to be remembered. And then that absolute refractory period was marked there. No, he put pointers like this. So you can see that when the fall is happening, then it is bisecting the 2/3 and the 1/3 of the way. Like if you look at the data, it is like 2/3 and 1/3 of the way that you need to remember for the because there were two markings there, right? One is the threshold, which is cutting here, and second was this marking that was given. So a lot of guys, they actually marked absolute refractive period as the marking that I've currently done. The thick one that I'm showing, it is the 2/3 and the 2/3 of the repolarization part that is happening. That's where the marking is to be done for absolute refractory period in a patient. Absolute refractory period is come whatever you do. I mean, the stimulus is not going to be responsible for firing of the nerve once again. Then are a couple of straightforward ones where like in one city, blood groups are mentioned in the same bar chart. There's sub fragmentations which are given, like people are having blood group O, blood group A, blood group AB. So this would become an example of a component bar chart, bar diagram. In bar diagram, like the diagram would not be, the data would not be contiguous. You'll be having gaps in between, and there would be component bar chart that would be present in this case. So this was again a spotter, I would say. Okay, next is capnography. We are checking for the end-tidal carbon dioxide values, and what you're getting here is a classical presentation of a shark fin. I mean, the moment you pick up that shark fin appearance present, it tells you that there is a significant bronchospasm occurring in a patient that could be triggered either by drugs, or it could be a manifestation of the disease process itself. So the correct answer in this case is option number A. Great, bronchospasm for the shark fin appearance of a capnography. Okay. Moving to the 15th one, the cardiac action potential shape is different. Now, when it comes to a nerve, you will noticing that the shape is different, but the cardiac action potential representation is a little different. Like I've currently marked before you, this would be having a more flat curve present here, and there are various phases of cardiac activity where you are having a depolarization, then a repolarization part, and a flat part as well. Okay, guys, so let's have a look at your interpretations for this one. That is phase 2 here. It corresponds to which particular part in the ECG. So when it comes to phase 0 and 1, they indicate ventricular depolarization. That is the QRS complex. And when it comes to phase 2, that is going to be the isoelectric segment. And when it comes to phase 3, that is going down, then it would be indicated for the T wave. So simple interpretations, ST is the isoelectric segment. The correct answer for this one is C. Phase 2 of cardiac action potential indicates ST segment in the ECG. It's the flat part that is to be remembered. Phase 01 QRS, phase 2 ST segment, and for like the phase 3 would be a T wave repolarization. That would be potassium channels. That's the inward potassium channel current that I'm talking about. So okay, Yeah, 3 is the T wave, as somebody commented rightly. So pretty easy one for this one. Okay, next is a quantitative data, and you can notice there is no gaps in between, so this would not be a bar diagram. I think it's not obviously a pictograph also, and neither is gonna be a box and a whisker plot. So the answer in this case would be given as A, that is a histogram representation. If the gaps in between, then we'll be saying the word bar diagram, bar graph for this particular patient. And okay, the SA node graph is totally different from the graph of the cardiac muscle fiber that I've currently shown here. The main difference in the SA node is the presence of the funny current. Please comment in the chat box which ions determine the funny current, and also comment on the channels. Which channels and which ion is contributing to funny current. For like this is the cardiac action potential, but then it is being driven by the SA node. Now the main pacemaker of the heart is SA node, which will cause the muscles to fire. So for the funny current, that is the IF current, what are the channels that are involved and what is the ion that is involved? Yeah, it would be sodium, that is the primary ion, and what are the channels that are involved there? Then they are called as HCN channels. So one, it is gonna be funny current, then is gonna be sodium, and then is gonna be the HCN channels. It is sodium, guys, for the funny current, not calcium, and it is the HCN channels which are involved for the funny current. Yeah, IF current. And which drug will inhibit the funny current? Inhibitor of the funny current, please. Yeah, ivabradine. I think somebody mentioned that correctly. Inhibitor of the funny current is ivabradine. So I think this graphical representation is pretty straightforward, unlike the one which we read with respect to SA node, where even the funny current component has to be incorporated. Okay, 16 is sorted. The next one is a negative. I mean, more you exercise, your body mass index will become lesser. So he says like, what is the correlation that is shown for this particular graph? I'm waiting for your answers for the current one. Yes, guys. I mean, hours a week and a body mass index, right? Okay. Yes, guys. Yep. Yep. Look at, I mean, that is okay. I mean, by all the things like you are suspecting, but then if you look at the representation in this case, don't go by the English for this. No, don't go by the English, because it can depend on the type of the exercise in the patient as well. It can depend on the type of exercise also. Now, if somebody is doing gym, then it can cause a left ventricular hypertrophy, and that can increase the cardiovascular mortality. I mean, we tell people not to work out in a gym. We tell them to do cardio in a patient. So here you have to go by the graphical representation. No? If you look at the graphical representation, this would be a negative correlation here. So it's not related to the English part, that BMI and the exercise part. It depends on the type of the exercise in the patient as well. So the correct answer for this one would be given as not as option number A. It would be given as option number B. That is the negative correlation that is happening. And the rationale is what I've said, that it's not dependent on like whether you are exercising in BMI. It is the type of the exercise that the person is also doing that will determine the cardiovascular status in a patient. The answer in this case is not A, guys. The answer would be given as a negative correlation. The answer for 17th is option number B. Now we will talk about a box and a whisker plot, and I would like you to read this carefully. Like there is the hospital is trying to analyze that there is a special surgical procedure that is being done, and we want to see the recovery rate, because after all, every hospital wants the hospital bed to generate revenue for them. So we have what is called as a bed turnover rate. Like every second day, every third day, if the bed is getting vacant, then I can admit a new patient and I can increase my hospital revenue. So that's why they're looking at the recovery times in this patient. And it would be the different way. No? It will go vertically up. No, like in this case, if it is positive, then it will go up like this. If it's a negative correlation, then it will be going down. The positive correlation will tend to go up, no, and the negative correlation would be going down. So here it is like a negative correlation happening, which is why I said the type of exercise can be deciding it. Okay. So if you look at this representation, the first and the foremost in the box and whisker plot is that it is very, very small, right? So it is middle clustered, right? There's no positive skew, there is no negative skew. I mean, the distance that is present is, yeah, it is zero skew for both of them. There are two of them, zero skews which are present, no? So yeah, I mean, we now need to look at whether we'll say the word long tail or whether we will say the word short tail. So that is dependent on one, the physical. I mean, if this question mentioned that values of Q1, Q2, Q3, then it is okay. But then the graphical representation I can say here is the zero. I mean, the graphical representation given here is with the long tail versus if the size of this box is relatively bigger, and the whiskers are relatively smaller in size, versus like the box is relatively chota and the whiskers are relatively bigger, the physical representations would be different. So I can talk about the median part and the Q1 and the Q3 component and compare with that, but all I'm saying is on a visual scale, like how would I pick up a one with a zero, I mean a short whisker versus a broad whisker is the visual representation that is mentioned here. Like the box is chota and the whiskers are relatively bigger, whereas the one that I've currently shown before you would be having like a short tail and the box size of the box is bigger. So the correct answer for the this question, I think, yeah, I think most people were able to just simply analyze it. The answer would be A for this one, middle clustered and a long tail that is present for this box and whisker plot. Good. I think we are on the reaching the penultimate part of our discussion. ROC, receiver operating curves. They are always used to determine the thresholds. ROCs are receiver operating curves. We use these curves to determine what is the best investigation. Like we say, that screening test for pulmonary embolisms, D-dimer, investigation choice is CTPA. So we compare two investigations on the basis of ROC curve, and depending on the higher area under the curve, like we will compare the two investigations, there's a possibility investigation number A, the area under the curve may be lesser as compared to the second one. So the one which will have more surface area below it is the investigation of choice, and the one with the lesser one will become relatively a screening test. So best investigation is where the curve is upward and left. That's understandable. As I said, higher the convexity in the curve, that implies that it is more accurate a test. It can be used to comparing two tests, so this also makes sense. But then if you look at C, he says minimum surface area under the curve is most effective. It is ulta, it is the maximum surface area in the curve that would be most effective. So option number C in this case can be ruled out. And then the optimal cutoffs, like we can use this test to determine what is the optimal cutoff for troponin I. Like earlier, the cutoff for troponin I was 0.1, then we decreased it to 0.04. That is high sensitivity troponin I, so that we can pick up even unstable angina. We can pick up non-ST elevation myocardial infarction / unstable angina where microinfarctions can occur. So we decided on basis of ROC curve to introduce a high sensitivity troponin I instead of a standard troponin I for detection, because unstable angina, it's not the main artery, it's the chota artery that got blocked. So threshold values, optimal cutoff values, like more than how much will we say MI in a patient. Like I said, trop I values more than 0.04 now is MI. When I was a student earlier, it was like 0.1. So we have tried to like increase the diagnostic accuracy of the disease there. The correct answer for this one is option number C, because it is wrongly written. The word minimum surface area under the curve, it should be maximum surface area under the curve. Okay, Ji, fine. We come to the next question, which is from NEET PG. This is NEET PG 25 only. There was a curve that was given where he described a case of pulmonary embolism. Like he mentioned the chap himself, he has written massive pulmonary embolism, and he says what is gonna be the effect on the ventilation perfusion curve. So I'm gonna mention normal here, like 45 is the value of PO2, and then I mentioned PCO2 something like 45. So I can say that this is normal. This is where the ventilation perfusion ratio would be like in a ratio of about 1:1. V by P is 1:1, and then we can be having is a V by P becoming lesser. It could be V by P becoming relatively more. For lesser, I can say it would be the base of the lung. For the lesser part, I can say base of the lung. Ventilation perfusion ratio more is with respect to the apex. But in pulmonary embolism, the bottom line is there would be no blood supply happening in a patient. So the value of V by P will become infinity. That would be point number D. So this is like D, which is to be correctly answered there. So yeah, I think Sonali, Rajesh, and Dhanush and a lot of other people. Yeah, ventilation perfusion ratio. Yeah, I'll mention the value as 0.8. Normal is like 0.8. For mathematical calculation, I'd mentioned that I had mentioned 1.0 there. So it is just that the VP ratio can decrease or increase depending on the lung disease present there. And well, we are on the last question for the today's session. So this was a quick analysis of the common graphs that we get. Some of them, like the initial ones, were a bit of hiccups, and the subsequent ones were really, I mean, the PSM graphs and the pharmacological graphs are pretty easy. It's the physiology ones which cause a bit of error of judgment. So I think like what you can see from this is that maximum importance need to be given to the graphical representations given in physiology, and there also, like, most guys were pretty spot on for identifying the valvular lesions that are described, or like the ABG interpretations that are present. So we are sorted for today, guys. Thank you so much, and this was a quick short discussion for the for the graphical representations that we need to remember. Thank you guys. Take care. God bless you.